to the next speaker, Dr. Ricardo Osorio, who's Associate Professor of Psychiatry and the Director of the Center for Sleep and Brain Health. His research focuses on age-dependent sleep changes and their relationship with neurodegenerative disorders. He uses a multidisciplinary approach to examine this issue, including looking at genetic factors, neuroimaging, AD-related biomarkers, neuromodulation, cognitive measures, and electrophysiological approaches. He's made seminal contributions to the relationship of sleep dysfunction and Alzheimer's disease. He's been highly productive with over 80 peer-reviewed publications, and he's been very successful at getting external funding for his studies. He'll be discussing sleep apnea in older adults, a great challenge for the future.
Thank you, Tom, for the great introduction. Thanks. So I chose this very provocative title because as we move from understanding better the natural history of Alzheimer's disease, we're going to have great challenge in trying to understand better the causes of the disease, and sleep apnea is one of them. So the traditional view of sleep and Alzheimer's is that Alzheimer's causes severe disruption of sleep. AD patients sleep more than usual or wake up disoriented, classically very sleepy during the day. In some cases, this is very severe and there's a complete reversal of the daytime wakefulness, nighttime sleep pattern, and they are sleepy during the day and awake during the night. And this is usually one of the most important causes of institutionalization. There are also other conditions like sundowning, which is a disruption of the circadian system, and there is an increased prevalence of sleep apnea. This is what we know since the very beginning of the first description of the disorder. What is new is that in 2009, there was a publication by Kang et al. In which they described that amyloid beta in the interstitial space had a diurnal variation. It was higher during the during the wake phase and lower during sleep in mice, and they also demonstrated it in humans. So this was the first evidence that amyloid beta, which is one of the two proteins that accumulates in Alzheimer's, had a diurnal pattern that could be explained by sleep, and really changed the way we see this problem. Sleep became a potential risk factor for Alzheimer's. And this has been then tested with multiple epidemiological studies. The last one came after a few months ago, in which they reported that short sleep duration increased the risk for Alzheimer's. But if we're interested in sleep, the elephant in the room is really sleep apnea. Due to the obesity epidemic, we know that sleep apnea prevalence is 9 to 25% in the general adult population, so it's very, very prevalent. But when we look at these numbers among the elderly, it goes up to from 20 to 84%. So almost everybody after a certain age has some degree of sleep apnea. Most common cases is mild to moderate. But this is using definitions of adults. So there's some people that are asking for new definitions of sleep apnea for the elderly. Sleep apnea is also 5 times more common in AD patients than in healthy controls. And these are classic studies from more than 10 years ago from Ankoli, Israel, in which she showed that AD patients that had sleep apnea, when you treated sleep apnea, they had an improvement in cognition. And not only that, she also showed in a few of those subjects that when you treated sleep apnea successfully with CPAP, you could delay the decline. And those AD patients that were on CPAP treatment had a decline that was slower than those that did not use treatment. So there's good evidence to point out that sleep apnea is important, and because of its frequency, it should be the first sleep disorder that we should understand better. In the field of sleep apnea, we are now acknowledging that the syndrome is more complex than we originally thought, and we are starting to talk about different phenotypes. The phenotypes of sleep apnea are usually divided into different causes of sleep apnea or also different consequences. The OSA elderly is clearly one of those phenotypes. The classic phenotype of sleep apnea would be the one that Charles Dickens described on his first book, the Pickwick Papers. Obese male that snores, that would be the classic definition of sleep apnea, When we look at the elderly, we can see that that classic definition doesn't match. Elderly with OSA are less likely to be men. They are less likely to be obese, or obesity is not so important as a risk factor. There is less snoring, or is underreported. And there's also less complaints of sleepiness and fatigue. The health consequences are also less debilitating. Some people would argue that because elderly are retired, they can also adapt better to the consequences of sleep deprivation. There's also less association with cardiovascular consequences, and they have also very commonly atypical presentations like cognitive impairment, repeated falls at night, secondary neurosis, and others. So it is different clinical presentation, and we need to understand this better. When we talk about sleep apnea, we're talking about intermittent hypoxia, arousals, and interthoracic pressure changes that are a consequence of the apneas. These three events will cause sympathetic activation, endothelial dysfunction, hypercoagulability, inflammation, oxidative stress, and this intermediate mechanism results in the consequences of sleep apnea that are very well known and well described, which are heart failure, hypertension, myocardial heart disease, a stroke, and increased mortality. And arrhythmias. We do not see this on the elderly. So when we talk about the elderly population, we do not see an excess mortality at age 70. We do not see an association with hypertension. There is no association with coronary heart disease, and there is no association with sleepiness. The only clear association that remains is the relationship between sleep apnea and stroke. There are several theories of why this occurs. The first and the most obvious one will be that there's a survival bias, that those people that have severe OSA with a more severe presentation would die, and we will only select those that survive. The second would be what is called ischemic preconditioning. So many of these elderly with OSA are exposed to chronic hypoxia over the years, and if the OSA is mild, this allows the heart to create vascular collaterals and to release vascular factors, and this would actually make them more resilient to new infarcts. And this was first proposed by an author from Israel called Lavi, which showed that elderly with OSA had increased survival rates to infarction. There's another hypothesis, which is that the response to apneas is just less strong. The elderly will have less strong sympathetic activation. When you have an apnea, there's a response in release of epinephrine and norepinephrine, and this causes increase in blood pressure and inflammation, etc. This response is less strong in the elderly, and this is the reason why the elderly would be protected from the effect of apneas. The effect on cognition is also being debated. This is a meta-analysis from Cross et al. That was published in 2017, and they reviewed 13 papers that included elderly between the ages of 55 and 82. 28% were women. And what they saw is that severity of sleep apnea was associated with a decrease in processing speed and declarative memory. This is one of the studies that reviewed the whole literature. But when you look at this paper more closely, what you see is that there is a publication bias. So I want to ask you to look at the what is circled on top. The studies that were done on sleep clinics were the ones that were driving this association. So there were two types of studies that were reviewed in this meta-analysis. One, studies that were done in sleep clinics. So sleep clinics characteristically include people that have severe presentation and that go to the sleep clinic because they have complaints. They have sleepiness, their bed partner complains of their snoring, or they're symptomatic in other ways. The ones that were done in the community were studies that were recruiting just normal elderly, and in which cases sleep apnea was in many cases diagnosed during the study. So the sleep apnea was asymptomatic. When we split the samples by those that are symptomatic and those that are asymptomatic, we see that the effect is driven by the symptomatic population. These are also papers that are epidemiological. There are just two of them at the very top, the ones from Jaffe and Chang, but there are 4 others. There was a meta-analysis recently that reviewed, and there were 2 million subjects in that meta-analysis, and they showed that OSA reported in clinical records was associated with increased risk for dementia. Again, these retrospective studies that were done with medical health records are talking about a population that are clinical patients, so people that go to the hospital because they have symptoms. When we look at these studies, we see a relationship between sleep apnea and dementia. And the same applies. These 2 studies below are from longitudinal cohorts in which they enroll a number of, in the case of the study from Jaffe, women, and the case of the study from Lutzi, the ARIC-PEP cohort, and they follow people over time, and they saw the same effect. But in this case, only the moderate and the severe cases had an association with increased risk for dementia. So in some, this is another study. This, in this case, comes from the Sleep Health study. This is a cohort in which they grouped subjects into 4 types of symptoms. Those that were minimally symptomatic in green, those that have disturbed sleep in terms of very fragmented sleep in blue, the moderately sleepy were in pink, and the orange are the excessively sleepy. And what this study from Mazzotti in 2019 described is that only those subjects that had sleep apnea and were sleepy were the ones that had new incident coronary vascular disease and cardiovascular disease. So in sum, we're talking about 3 types of populations. We will have ones that have moderate OSA. We also have those subjects that are symptomatic. They have sleepiness, or they may have some other cardiovascular consequence. These would be the subjects that have OSA and have sleep complaints. And we have the majority, which are the asymptomatic ones that have very few symptoms. They're not sleepy. They have no complaints. And in many of these cases, their sleep apnea is asymptomatic or unrecognized. And we see a lot of these subjects in our studies. They enroll in our studies thinking that they are healthy, and we tell them that they have moderate to severe sleep apnea and that they should go to the doctor. This is a paper that I published with Nadia Gosselin, and we reviewed all the potential mechanisms that would explain the relationship between sleep apnea and Alzheimer's disease. Both intermittent hypoxia and sleep fragmentation are associated with the increased risk, and this could be mediated by reduced neurogenesis, small vessel disease, changes in brain structure, or accumulation of plaques and tangles. It could also be moderated by some of the intermediate mechanisms that we described before, such as diabetes, oxidative stress, inflammation, hypertension, etc. I'm not going to describe all of these mechanisms. I'm going to try to focus on the disruption of the macro and microarchitecture of sleep, because that's where there's been more progress and there's more interesting papers that have been published in the recent years. So we have to go back to 2012 to talk about the disruption of the macro and microstructure of sleep and how it relates to risk for AD. And we have to discuss the glymphatic system. So before 2012, it was a bit of an enigma how the brain would clean their waste. The brain lacks a lymphatic system or waste removal. And this paper from Ilif and Nerdegaard in 2012 described for the first time that there was a parallel system where the CSF would enter along pararterial channels, and then it would move by convective bulk flow through aquaporin channels and clean all this waste, and then it would exit the interstitial space through paravenous channels. This was a new description of the system, and it was coined by them the glymphatic system. But this does not describe how sleep is related to it. This was later published in a paper in Science, in which they developed a system in 2-photon microscopy in mice, in which they injected cerebrospinal fluid in their interstitial space. And what they analyzed 3 types of mice. They analyzed mice that were on sleep, awake, or anesthetized. And what they saw is that the CSF influx was much larger during the sleep phase. So we're looking, if you look at the chart in blue, on the left, the diffusion of CSF is shown in green, and during the sleep phase, and the diffusion of CSF is in orange during the awake. So much larger diffusion of CSF while the mice were awake. And they replicated the same phenomena when the mice were anesthetized. They looked within sleep to which stage of sleep would be more associated with this increase in CSF influx. And what they saw is that it was the delta sleep that was the stage of sleep that will be produce the higher influx. The sleep is divided into REM and non-REM sleep, and within non-REM sleep, we have this stage that is called deep sleep or delta sleep. This was the stage in which the CSF influx was larger. This is also the state in which there is increased parasympathetic tone and a decrease in cerebral blood flow. They also saw that the clearance of amyloid beta was more efficient during delta sleep. But this doesn't explain how cerebral blood flow and CSF flow is regulated. This has been very nicely explained in a paper from 2019 by Foots. And what they did is they did simultaneous measurement of EEG, BOLT, and CSF flow in 13 subjects that were sleeping inside an MRI machine. And I want you all to look at the chart on the top on the left, A, which shows that during wake, CSF flow is very low in amplitude and is synchronized with respiration. So they were looking at CSF flow in the fourth ventricle, and it's low in amplitude and synchronized with respiration. What they saw is that during the wake phase, the CSF flow is much higher and is anti-correlated to blood flow. We can see this on the chart on the right. We see that there's first slow oscillation. This slow oscillation is followed by a decrease in cerebral blood flow, and this is when the CSF flow is at its maximum. So during slow sleep, there's a decrease in cerebral blood flow, and this would probably facilitate that the CSF influx is larger. Another study from, in this case, the Nerdegaard group, in which they use in vivo measurements of CSF flow using microspheres, and they also recorded cardiac and respiratory cycles and artery diameter. And what we can see in the image on the left is that there are areas of high and low flow, and we can see that at the bifurcations of the arteries, there is very low CSF flow, and the bifurcation of the arteries is a very common place where there is amyloid beta accumulation. So this could be one of the explanations. They then recorded the peak in arterial wall velocity, and they showed that it coincided with the peak in CSF microsphere velocity, and they thought that local displacement of the arterial wall was driven by these changes in arterial wall, and they coined this perivascular pumping. So they believe that there is a need for a functional perivascular structure to secrete the CSF into the interstitial space. They then looked at subjects that have hypertension, and they showed that the forward flow and backward flow in patients with hypertension is much impaired. And this could be one of the reasons why hypertension is associated with increased AD risk. Going back to our studies, so we're going back to clinical studies that we do in our lab. This is a paper that we published in 2018. We enrolled a group of 180 normal elderly from the community, and we followed them over time. So 98 of these subjects had 2 lumbar punctures spaced over 2 years, and they had measurements of sleep apnea severity at baseline and follow-up. And what we saw is that those people that have moderate to severe sleep apnea had a decrease in levels of CSF beta over time. In other words, severity of sleep apnea was associated with a decrease in A beta 42 levels, which is usually associated with an increase in amyloid burden. And we were able to replicate this result in 40 subjects that had both baseline and follow-up PIB PET scans. These relationships are, again, not very strong. As you can see, the R value was not very strong on the CSF cohort, and on the PET study, it was just a trend towards significance. So there's a lot of heterogeneity, and this could be maybe explained by what I mentioned before about the slow sleep disruption and the hypertension. These are studies that are actually being performed at this moment. This is preliminary data for one of my junior faculty, Dr. Michael Bubu, and he's looking at the longitudinal trajectories of different sleep apnea populations. On yellow, it would be a group of people with OSA and no hypertension. Gray would be patients with OSA but no hypertension, and then orange and blue would be the hypertensive with sleep apnea and without. And what Michael is seeing on this very preliminary study is that the longitudinal decline in cognition is much larger on those patients that have sleep apnea and hypertension. So we're looking very closely now in our data at the elderly with OSA and hypertension, but also at the how disrupted slow wave sleep is on our population with sleep apnea. This is my last slide. This is a paper again from Washington University. They enrolled 17 patients, mean age was 54, and what they describe is a positive correlation between slow wave sleep and amyloid beta. The higher the delta power, the lower the CSF A beta. In other words, the more slow wave sleep you have, the lower the levels of your A beta are going to be at cross-section. And what they also describe is a group of subjects that had sleep apnea, and among the sleep apnea subjects, this relationship between between slow wave sleep and A beta was non-existent. What they showed is that if you treat these patients with sleep apnea after 3 months, and this is what they're describing in this slide, they're looking at the change in delta power. When they treated these patients with sleep apnea over 3 months, and these patients with sleep apnea recovered their normal sleeping pattern, they saw again this ratio between slow wave sleep and amyloid beta change. So if you have sleep apnea and your slow wave sleep is disrupted, if we recover your slow wave sleep by treating it with CPAP, you will regain the normal association between slow wave sleep and A beta. So this is pointing out that the slow wave sleep is disrupted in patients with OSA, and recovering quality of slow wave sleep via CPAP or other treatments might be the way to go. And this is what we plan to test in the coming years. So to conclude, there is a need to understand better sleep apnea in the elderly, both at the phenotypical level and in the way we measure OSA severity. We're measuring OSA severity using methods that are applied to middle age. We probably need new criteria to define sleep apnea in the elderly. There is impaired clearance through disruption of slow wave sleep and disruption of perivascular pumping. This is a potential mechanism with important physiophysiological consequences that we don't understand. We still need to understand better how a slow wave sleep is disrupted by sleep apnea. Some phenotypes, like patients with OSA and sleepiness, OSA with disruption of slow wave sleep and hypertension might be the subgroups that are at higher risk for AD, and we need to try to characterize them better. And we also need to understand much better the importance of slow wave sleep, or also called deep sleep, and how it affects brain physiology and brain health. And these are all my collaborators, and thank you very much for inviting me.
Thank you, Dr. Osorio, for a wonderful talk. We're open to a couple of questions.
I have a quick question, Thomas. Ricardo, I really appreciate this. I think it's a sort of a very much understudied aspect of the AD pathophysiology. I was wondering, and I was trying to think back about Maiken's work on the glymphatic system, if you know if there are sexual differences in that dysfunction that occur during AD. So is the clearance or the glymphatic clearance dysfunction more apparent in females over males, for instance, or is there no sex difference at all?
I don't know. What I can tell you is that females have more slow wave sleep than males in humans. I don't know in mice. Sleep, as many psychiatric conditions, it has an important sexual dimorphism in humans. So women have more slow wave sleep and also more sleep spindles than men. But also, the fact that they have more doesn't mean that they're more protected. As you know, there's the menopause and many things that disrupt women through their lifespan. So I think that could also make them more vulnerable.
Thanks.
So if there are no more questions, I think we can take a break now for 10 minutes and resume with Dr. Lidlow giving his talk at 2:50.